Okay.
Probably
what are the causes? Okay, tell me some important common causes of hematuria that we are encountering in pediatric practice.
Mostly hematuria can be due to glomerular or non-glomerular causes. In glomerular, it may be due to IgA nephropathy, membranous proliferative glomerular nephritis, rapidly progressing glomerular nephritis, post-streptococcal glomerular nephritis, Alport syndrome.
What is the color of the hematuria?
Color of the urine was cola-colored urine.
Okay, that is specifying what?
Cola-colored urine mostly denotes post-streptococcal glomerular nephritis.
That means it's glomerular involvement, right?
Yes, ma'am.
Cola-colored is not specific for post-streptococcal. Cola-colored generally is trying to suggest you that it is coming from upper tract. So most likely you're looking at a glomerular cause of hematuria.
Okay, sir.
What else? What other history will you ask from this only? Any other change in the urine will happen? Apart from this, any other change in the urine will happen, which you will want to specifically ask the mother?
Pain during maturation.
Okay. Specific to the urine, I'm asking. One is you ask about the color, then you ask if there any pain.
Frequency of maturation.
Okay, frequency of maturation. Okay. Now, if the mother says it was also frothy, what does it mean? If the mother says, along with hematuria, child passed cola-colored urine, and also she found that it is frothy. What does it mean? Yes, yeah. So these are all giving you history. From history only, you're getting clues that probably you're looking at a glomerular cause of hematuria. Okay. Go on.
Now, child usually passes urine 8 to 10 times a day, but gradually reduced to 4 to 6 times per day. 2 days back, reduced to 1 to 2 times per day for past 1 day.
Okay, what is a normal urine output for pediatrics? How will you calculate normal urine output?
Normally will be more than 4 ml per kg per 1 to 4.
What is oliguria? What is normal? What is polyuria? Can you define? Because you are telling the child is oliguric, right?
Oliguria is less than 0.5 ml per kg per hour, and polyuria is more than 4 ml per kg per hour.
Okay. So this child is having some oliguria. So child is having edema, from your history, edema and hematuria, oliguria, right?
Yes.
Okay, you proceed then other history. What else you want? I mean, you want other history, you want to get it from the patient. Please proceed.
No history of dribbling of urine. No history of.
When will you get dribbling of urine? When will you get dribbling of urine? What are the causes?
Urinary status. Abnormal urine insertion. Abnormal anatomical insertion of urine.
Okay. Next.
No history of difficulty in passing urine. No history of fever, chills and dryness. No history of
You explain why you are asking also, as you tell.
Sir, history of fever and chills and dryness is used to rule out UTI, sir.
Okay, so are you only going to say UTI or something else? Where is the infection localized within the urinary tract? Does it give you a clue? A UTI child with chills and rigor and another UTI child who is otherwise well. Does it help you differentiate amongst the UTI only? Where is the localization? Are you looking at the lower tract? Are you looking at the upper tract? Does it give you any clue? Yeah. So what do you call urinary tract infection involving the upper tract? Medically? Yeah. So child with fever with chills and rigor, you're thinking more of pyelonephritis. Okay. Otherwise, if it is a cystitis child might be very happy around. Only at the time of passing urine, child has some dysuria and he has having some fever. Okay, so that's why you wanted to rule it out. Okay, go on.
Excuse me. Hello. Are everything here? in this point you told that, are you able to hear me?
Yeah, Dr. Jagan, you are audible, please.
Yes, sir.
You have clearly mentioned that there is a cola-colored urine, it's a involving glomerulus. With the glomerular involvement, how can you justify this fever with chills? That is UTI. The glomerular involvement with the gross hematuria that makes it precipitated by UTI. What is the nephropathy? Probably that is rare in idiot. You told it's a glomerular involvement. Hematuria is cola color. Now
Yes, sir.
you are asking for a fever with cell tiger. IgA nephropathy. IgA nephropathy is usually precipitated by pericarditis. Sometimes it will be also precipitated by the urinary tract infection. We able to get. Hello.
Sir, your audio is not clear, sir.
Okay, madam. I will come back. Okay, proceed, madam. Come back.
Yes.
No history of headache, no history of blurring of vision, no history of convulsions.
No. Go back to no history of breathing difficulty and decreased. No history of breathing difficulty. Why are you asking for that?
Pulmonary edema, cardiac cause, cardiac failure.
Yes. Why you are getting congestive cardiac failure in nephrotics and nephritis or
Increased hydrostatic pressure.
okay, hyperolemia, right? Retention of flow. Okay.
Retention of fluids.
Okay.
No history of blurring of vision, no history of convulsions, no history of allergies.
Why all this history?
To rule out the hypertensive encephalopathy, sir.
Okay. So, how common is hypertension in this setting? Do you think hypertension is common?
Sir, hypertension will be presented in post-streptococcal glomerular nephritis.
So most of your acute glomerular nephritis, you would generally expect that they remain hypertensive. So that's why you want to rule out all these history. Okay, go on.
No history of yellowish discoloration of urine, no history of itching, no history of rash.
So what rash are you interested in? Can you describe what kind of rash you tried to ask the mother?
Malar rash. To rule out.
What does the malar rash suggest?
To rule out SLE, sir.
Okay. Any other rash you are interested in? Very good. One is malar rash.
Purpura to rule out HSP.
Yes, very good. So, what history did you ask specifically to think about Henoch-Schönlein? How did you ask the mother and rule out Henoch-Schönlein in this child?
Any history of any abdomen pain, small petechiae over lower and extremities.
So, what is the typical distribution of a rash of HSP? Sorry? Yeah. So, they are lower limb predominant rash. Typically, history mother will also say the lower limb predominant, usually symmetrical, bilaterally symmetrical, and it extends up to the gluteal region. So that is a typical history. What is the typical finding you see on examination? You find something. What is so characteristic in HSP? Yeah, so they are palpable. So mother also, if you take a good history, mother will also tell there are a lot of reddish spots all over the legs and buttocks, and she was able to touch and feel those reddish spots. So that will be the typical history which mother will give. So when you say there's no history of rash, we expect that you have asked this kind of a history to take from the mother. Otherwise, mother would not know, right? So we should ask specifically this kind of history and then you tell me that there was no history of rash.
Yeah,
then you have ruled out.
9:40.
Okay. Okay, go on.
No history of insect bite, no history of any drug intake, no history of any allergic food intake.
What drugs can cause hematuria? What are the drugs that can cause discolored urine?
Rifampicin.
Okay. Any food intake can cause discoloration of your discoloration?
Beetroot injection, dyes.
Okay. Okay. Okay.
So why did you ask for joint pain and swelling?
SLTC.
Okay, so what is the characteristic of joint involvement in lupus? Is it confined to one joint? Is it like multiple joints? Is it lower limb? Is it upper limb? What do you get? No. It is not non-erosive. It is nicely erosive arthritis only. Maybe many times it is polyarticular, maybe also involving the upper limb joints also. Okay. Many times if you don't get typical history, a polyarticular JEA, you will always try and rule out lupus in such children, right? So anything other than monoarticular JEA, like if child comes only with right knee swelling, then you might not upfront think about lupus, but otherwise lupus can also be under your consideration. Fine. Okay, go on.
No history of constipation or mood swings, no history of blood transfusion, no history of any bleeding manifestations.
Why did you ask for blood transfusion?
To rule out any hepatitis.
Oh, in the past you mean?
Past.
Assist.
Okay, fine. Okay. Will hepatitis cause hematuria?
Also hepatitis to rule out any hepatic cause of edema or hepatic fail. Cirrhosis.
Okay, so then for that you should first ask icterus, no? I don't see icterus at all. Jaundice, did you tell jaundice?
Yes, so the previous history,
Alright. Yes, told. Okay, fine. Okay. All right. Carry on.
Past history. Child was admitted in Sivagam Medical College at 5 years of age. He presented with hematuria and hypertension as he was diagnosed and treated as acute glomerulonephritis. University study revealed bilateral medical renal
No, wait.
disease.
Don't go to the ultrasound now. With this past history, this is very important history, no? So what does it tell you? What does this history tell you?
This might be a recurrent episode.
So now once it becomes recurrent glomerulonephritis, now what disease becomes less common? If you had not, I'll put it in another way. If you have not got this history and then you child presents with this typical history, what will be a diagnosis? And if the child gives you this history, then how will you revise your diagnosis? What will be your revised diagnosis now? So this is important. That's why I'm trying to stress this.
IML.
Yeah, you're telling only. Tell that.
இது ஒன்னு கொடுத்துறோம் மாண்டக்கல் அதுல 5 ml கொடுத்துறோம் அதுல 2.5 ml மட்டும் கொடுத்துறோம்.
Be a post-infective glomerulonephritis, the recurrent episode, sir.
So if you have a recurrent hematuria, what will you think? You will think of post PIGA?
Any systemic involvement, any bleeding, vacuum malformation, bleeding resistance, bleeding.
If there is a systemic involvement is correct, but bleeding you should not tell. Bleeding will not cause a glomerular this kind of hematuria findings, no? The kind of history you told associated with oliguria, developed all this hypertension and all that, then you won't think of those things. Now, important history is once you get a past history of this, then PIGN becomes very, very less likely. You understand? Because it is not going to keep on recurring like this. So if you have it for the first time in any child who comes to you with this kind of history, typical history, the first differential almost always will remain post-infectious glomerulonephritis, and most likely it's going to be post-streptococcal. But if you have a history of a similar episode in the past, then PIGN no longer remains your first different diagnosis. Okay, so it goes down your differential. And you have to entertain other systemic causes and other possibilities which is causing a recurrent glomerulonephritis. You understand? So that's why this history is very important, and that's why I wanted to stress this point. Yeah. Okay. Now move on.
University study revealed bilateral medical renal disease with increased cortical echoes in 2017, treated with tablet nifedipine and he got discharged. And child was not on regular follow-up and not on any medications. No issue previous episodes of any seizure. No, it's not a known case of hypothyroidism or congenital heart.
Okay. Any
Tell me some-
kidneys? Okay. Sorry, ma'am. Go on.
Yes, sir. Tell me some nephritis with recurrence. Just- Yes,
Lupus,
IgA nephropathy. Yes, very good then.
ma'am.
So your audio is not clear. Please check it out. Hindu and Uma Shanti. Yes. Tell me some- Yes, Alport.
IgA nephropathy.
Yes, as sir told, from this simple history, you have to travel away from the post-streptococcal glomerulonephritis. So you should think of other causes of recurrent glomerulonephritis like IgA nephropathy, Alport's, right? Okay. With this idea, you should travel to the examination and the further investigations. Sir, please.
Okay. I just wanted to ask when the ultrasound was done. This is from the history you asked, right? You didn't have.
No, the discharge summary the patient is having, sir. From that.
Okay. Fine. I'll just go over the chat once so that we don't miss on any questions which I asked there also. Okay. So what drugs produce hematuria? I think we had discussed that. How to differentiate between red urine and hematuria? Yeah. So, Dr. Indu, let us know. How will you differentiate? Is all red urine only hematuria?
So in red microscopy examination, there will be no RBCs or savings.
Sorry, your voice is breaking. Can you tell again?
In red urine examination, RBCs are not seen, sir. Microscopic evaluation, sir.
Okay, very good. So all red colored urine is not hematuria. Correct. So only if you find RBCs in urine, you are going to call it hematuria. How many RBCs are needed to call hematuria?
More than 5 RBCs per high power fields.
In what? Sorry, in what urine?
Centrifuge.
Okay, so it is more than 5 in centrifuge urine, more than 10 in uncentrifuged urine. Okay. So what if there is no RBCs in urine, but still urine looks red in color? Now what will you think? Now what are your differentials?
Hemoglobinuria.
Very good. Hemoglobinuria. Can you tell any condition where hemoglobinuria can occur?
Nocturnal paroxysmal.
Okay, PR nights. What else? Yeah. Okay. What else? One is hemoglobinuria. What else?
Myoglobinuria.
Very good. Myoglobinuria can also cause this. So what causes myoglobinuria? In which setting will you think of myoglobinuria?
Rhabdomyolysis related with the increased muscle creatine X.
Yes, very good. So if there is any history of rhabdomyolysis, typical history is there, then you definitely think of myoglobinuria, which could also cause a red urine-like picture. Okay. Okay, fine. Apart from that, always remember to ask about history of drug and any recent, what is the food intake, because all these are common things we see in the clinics, and then we end up thinking everybody is only hematuria. But given this typical history, you will only think of hematuria. But just to get the message across that not all red urine is hematuria. Fine? Unless you find RBCs in that urine, then that red urine is not probably hematuria. There could be other causes also. Okay, another question they've asked in chat box: is there any history of throat infection?
No, sir.
Why is sir asking this?
To rule out post-streptococcal pulmonary.
Okay, so what is the difference between throat infection causing PSGN and skin infection later on developing PSGN?
Skin infection mostly more than skin infection, throat infection causes PSGN, sir. Because skin infection age title will be less.
Okay.
Post-pyoderma.
Is there a difference in timing when they develop? Hematuria following a throat infection, hematuria following a pyoderma. Is there a difference in timing? Who develops earlier? Who develops earlier? Who develops later? Sorry. Can you tell again?
Post PSGN will develop a post sore throat early, sir. when compared to pyoderma.
Yeah, yeah. So what is the average time when throat infection develops and skin infection develops? Sorry.
21 days.
Yeah, yeah. So generally 7 to 10 days after a sore throat like illness, you develop a post-streptococcal glomerulonephritis like picture in throat infection. Generally about 2 to 3 weeks after a pyoderma is when you get, but you may get it even earlier by about 7 to 10 days also you can get it. Okay. So that's why that history is also important. Now, another comment is idiopathic hypercalciuria should also be considered in recurrent hematuria. Yes, so that is also another cause. When ma'am asked you what are the causes for recurrent hematuria, again, whenever somebody asks you causes for hematuria, again classify as glomerular, non-glomerular, and then list causes in each, so that you don't miss them. Okay. Otherwise, in attention, you'll tell 2 points and then you'll forget. So it's always important to classify them. If you classify, you'll be able to tell everything clearly. Fine. Okay. Okay. Go on.
Antenatal history. Primary 23-year-old booked and immunized regular AN visits, took iron and folic acid tablets regularly, no history of any fever, rash in all 3 trimesters, no history of any drug intake or radiation exposure, quickening felt at 5th month, persistent fetal movements, Likert value was adequate in all antenatal scan, anomaly scan, no anomaly was detected, no history of GDM, hypertension or hypothyroidism in mother. Birth history, 38 weeks, normal vaginal delivery, birth weight of 2.5 kg, baby cried immediately after birth, breastfeeding initiated immediately, no history of NICU admission, immediate postnatal and neonatal periods are antiviral. Developmental history, developmentally is a normal school-going child with a good scholastic performance, no history of delayed milestones. Immunization history is immunized as per IAP schedule, last immunization at 10 years of age, pneumococcal or influenza vaccine was not given.
Excuse me.
Sir?
Are you able to hear? Are you
Yes,
able to
sir.
hear?
Yes, sir.
In the immunization, what are the vaccines which can precipitate hematuria? Actually, in adults patient last year, most of the COVID vaccines, nearly 20 to 30%, there is an increased risk of hematuria is there. But when coming to the pediatrics, the patient is already, am I audible?
Yes,
Yes,
sir.
Am I audible? And already there is a previous, when there is a previous IgA nephropathy within the patient, then there is a high chance of the patient developing the recurrence or hematuria. Hello?
Okay, sir.
Okay, proceed.
Family history is a firstborn child of non-consanguineous marriage, no history of renal diseases in family members, no history of early death or recurrent abortion, no history of contact with
What specific history did you ask? What did you mean by no history of renal diseases in family members? What all did you ask?
Family members?
Alport syndrome, sir.
So what did you ask specifically for Alport syndrome?
Familial benign hematuria.
No, for Alport syndrome, what did you ask? Parents will not know they had Alport syndrome. So what history did you ask? Sorry?
Who will get the sensitive? To whom you will ask the history? It's a maternal uncle. Are you able to get?
வேணாம் போதும் சரி போ சரி போ சரி பாய்.
Hello.
Yes, sir. So you're audible.
Excuse me, Dr. Jagan, can I interrupt?
Yes.
Can I ask a question, Dr.
Yes, sir.
Jagan?
Yes, sir.
Hello?
Yes, sir.
When do you really call it as recurrent hematuria? How many episodes should be present to call it as recurrent hematuria? In what duration of time? Have you to take it as 2 different episodes of hematuria, or just 2 episodes itself we call it as recurrent? Because the label that was given was recurrent hematuria. In fact, if it is a recurrent hematuria,
So
we will have to, the history itself, we have to say so many attacks over a period of 5 years or like that. Please clarify, sir.
It's not like that, sir. There is no clear-cut definition for recurrent hematuria, sir. Like relapse in the nephrotic syndrome, there is no clear-cut definition here. But the point is, when the patient is having hematuria and you are suspecting a AGN, there is no need for biopsy at the first time. If the patient has a recurrent hematuria after 1 month, then you have to go for definitely biopsy. That is the only place where can use that. Otherwise, there is no specific term we can use as recurrent hematuria, this much episode or that. There is no specific term like that.
In between 5th year and 10 years, that is the present time, is there a possibility that a child had microscopic hematuria? That's one question. Second is, I have come across typical post-streptococcal acute, though you know it's only a single attack in a lifetime. I have seen a few quite over the past 40 years, 1 or 2 cases of recurrent with all proven factors, investigation also as post-streptococcal glomerulonephritis or acute glomerulonephritis. What's your comment on this?
Sir, still it is possible, theoretically possible, sir. If it is going to be a second different strain of the streptococcus, then it is theoretically possible. But when it comes in the second time, definitely we have to go for biopsy to rule out membranoproliferative glomerulonephritis or C3 glomerulopathy or HSP. So straight away we can't label as IRGN, that is post-streptococcal in the second episode, sir. Otherwise, it is theoretically possible, particularly if there is a thing that there is second serotype is involved.
Yes, sir, possible. This is the point I want to emphasize, and you have highlighted that. Thank you, sir.
Thank you, sir.
Okay, so going back,
Interesting.
so this family history, what else did you ask? One is, what did you specifically ask? That is a question here. By renal disease, what did you inquire in the family members? What all did you inquire?
For symptoms pertaining to Alport syndrome, sir, asked about any kidney renal failure patients in the family.
Okay.
Any sensory hearing loss.
Who are you worried about? Renal failure patient in the father's side, renal failure patient in the maternal side?
Mother, but
Why?
next link to so mothers.
Why did you ask about maternal side? Okay. So X-link, that's why you wanted to ask about maternal. So the chief people who will be involved will be, you should ask Mama. Mama Kirnada, that is the most important history you should ask. Thai Mama Kirnada, because maternal, and that is how it keeps spreading in the family, right? So all the males get affected, females are carriers and they spread. But the concept in Alportus, it is not that females are only benign carriers, they also develop disease by their 5th to 6th decade of life. So it's not as benign as we think they are. Okay. What else did you ask? One is you asked for history of renal failure. Then you asked for history of what else?
Hearing loss.
Yes, very good. So there is history of sensory neural hearing loss. Okay. So by what age do you expect sensory neural hearing loss to happen?
Sorry, sir.
By what age do you expect sensory neural hearing loss to happen? Sorry? You're not audible.
10 to 15 years, sir.
Okay, yeah. So when you have asked this history in the child itself, so you will very well ask the history in the adult parent also, right? So likely that they will have. But remember, it's variable proportion. Absence of that history does not rule out. Okay, that is another thing you should remember. All these things, changes keep evolving with time. Just that at one time point you saw that there's no hearing loss does not mean patient does not have hearing loss. It may evolve. So 2-3 years later, if you have repeated a pure tone, you would have identified that there is already sensory neural hearing loss coming up. Okay. What else did you ask? Hearing loss you asked. Anything else? Sorry? Okay. What happens to vision?
And cataract, any macular anterior lenticonus, sir.
So how will they manifest clinically? So these are things unless you see in the mic, see elicit, no, you do a slit lamp, you won't pick up anterior lenticonus properly. If you don't do a fundus, you won't get macular flex and all, no? What will they manifest as clinically? Will there be vision loss or not?
Vision loss, sir.
Okay, so vision loss generally does not happen much earlier. It takes very much longer, then only they develop vision loss. Okay, so vision loss is not very prominent. Okay, so and what else will you ask? Did you ask for any history of stone disease in the family members? Again, here also, can it be idiopathic hypercalciuria? Yeah, so that is also possible. No, it can be oxaluria. It can be any of these different stones which has caused. Okay, but given that typical history you have told, now we are thinking all those things are less likely, and we want to entertain a glomerular etiology in this patient, right? That's why we asked for all the other histories. Okay, okay, go on.
Diet history, expected calories per day, 1,660 calories, proteins 35 grams, calories intake 1,060 calories, and proteins 28.2 grams, energy deficit of 600 kilocalories, and protein 6.8 grams per day.
So where did you get this expected calorie number from? 1,660 and 35 grams. How did you calculate 1,660 and 35 grams?
Weight of the child is 28 kg, sir. For first 10 kg, 1,000 kilocalories, and for the next is 50 kilocalories, and for our next kg, 20 kilocalories.
Okay, so this holiday sagar method is a very, I agree, it's a rough method by which we calculate. But do we have any Indian standards where you can compare and say? What is the reference? So like they say, no, an adult reference male, adult reference female should take this much, pregnant women should take this much, children of various ages should take this much. So what is the source for all this? Somebody has given guidelines for various age groups. They've given cutoffs for how much calories they should take, how much proteins they should take. Any guidelines have come up? Apparently it has come around the COVID time only. Recent guidelines have also come. So the ICMR, National Institute of Nutrition together, no? ICMR, NIN, they have brought out guidelines for various age groups. So there is a table where they mention how much calories for well children. So this is not for diseased children, for apparently well children of various age groups. So they have divided into three years age bracket, like 1 to 3 years. What is the expected calorie? What is the protein to be taken? 4, 5, 6, 7, 8, 9. Then from 10 years onwards, boys and girls are separately given. So the correct way to do about is to see that and then say, on a rough calculation, all this holiday sagar method is okay. But you should at least be able to know the theory behind this and be able to answer this. Okay. So go home and read this today. ICMR chart, there is one table, how much calorie to be given, how much protein to be given, and that is the Indian reference. It is done after so much research has gone into it, and then the ICMR has revised it after a very long time, after more than a decade. So you should be able to know this. Okay. Okay. So what diet change you want in this child? This child is already puffy, oliguric. Mother will ask you, no, the moment you admit, child admit, Amma, ennama saapadu kudukano, enna kudukudadu, they'll ask you, no. So what will you suggest? Sorry?
No restriction, no added salts.
No added salt is what you're telling? I'm scared. Okay. So you want a salt restricted. What else?
Fluid restriction.
So you want to restrict fluids also. So you want a salt restricted, fluid restricted diet. Okay. Okay. So we'll discuss more about diet as we discuss management. Okay. Go on.
Socioeconomic history, father, total score is 8, and according to Modified Scale, family comes under upper lower class, house type worker, the number of inhabitants in the house 4, is a separate kitchen with the number of single room. Provisional diagnosis, A 10-year-old male child firstborn out of non-consanguineous marriage presenting with second episode of facial puffiness, hematuria, decreased urine output. The most probable system involved is renal, probably nephritic syndrome. General examination. Child is conscious, oriented, afebrile, Janus plus, bilateral pittal feeding erythema plus, no cyanosis, pallor, clubbing, lymphadenopathy, no signs of dehydration, no rash. 8-foot examination. Face, no facial features presenting to congenital anomaly, no malar rash. Eyes were normal, fundus
What
normal.
congenital anomaly? What congenital anomaly did you think? Sorry? Okay, you just asked as part of routine history. Okay.
Fundus normal.
Okay.
No,
Fundus.
no,
Okay. Normal. Okay.
no residual throat infection, no oral ulcers, no uremic breath, ears normal, neck no JVP elevation, nails no white lines, chest no obvious
Hello.
deformities, skin no scars striated. Genitalia scrotal edema plus. Vitals, pulse rate 82 per minute, regular in rhythm, normal volume, felt equally in non-peripheral pulses, BP 160, 110 mmHg, more than 99%, respiratory rate 26
What
per
is
minute.
this? What is this 99%? From where did you see this? So what do the revised guidelines endorse? Okay, so when has the last hypertension guidelines come in children? So this 99 centile is all old, isn't it? Some new guidelines have come in 2017. That itself is now old, almost half a decade. So AAP 2017 has come up with guidelines, no, which is endorsed by American Heart Association also. So do they give 99 centile anymore? Or how do they classify hypertension? How do they classify hypertension then? Okay, based on age, gender, and height, you're going to look at those charts and then classify them into what are the centiles given there?
Sorry, sir.
What are the centiles described in that chart? Okay, so you have to go and read today. So this 99 centile term is no longer relevant, okay? The guidelines have all changed. It's more than 95, 95 plus 12. You should be able to tell us in that. So what do you think? This is stage 1, stage 2? What is the stage of hypertension in this child? Stage 1 or stage 2? Yeah. So why are you thinking so much? 160, 110 is a lot, no? Even for an adult, 160, 110 is a lot. A 10-year-old child, 160, 110 is a lot. So it is already stage 2 hypertension. Now, what is the cause for hypertension in this patient? Considering that patient has a GL.
Cause for hypertension, most renin activating systems.
Why do you think renin system gets activated?
Hypoalbuminemia.
Okay.
Oncotic pressure.
Okay.
GFR is reduced, so renin activating system gets activated. Renin aldosterone system gets activated.
Yeah. So what happens because of that?
Most of the water retention which increases hypovolemia.
Yeah, so that's why all this hyperolemia, fluid retention, kidneys now frantically think that there is no blood supply to it. So now it's trying to conserve everything. So all your salt, water, everything gets reabsorbed. So there is hypervolemic state and secondary RAS pathway is activated. That's why you're having hypertension. Okay. Okay, go on. All peripheral pulses are equally felt. Okay, so you have checked that, no? Why is that relevant in this patient? I mean, in any child with hypertension, not in this patient. Okay, what happens in coarctation? Sorry? What happens in coarctation? What will happen to peripheral pulses, central pulses? What changes do you expect?
Radiofemoral delay.
Sorry? Okay,
Radiofemoral
radiofemoral delay is there. So if you feel the popliteal, how will it be? In coarctation.
bounding.
Probably will be bounding in coarct. Basically, there is obstruction, no? There is obstruction, tight stenosis at higher up. The lower limb supply is already compromised. Why would popliteal? Yeah. Okay, so tell some other causes for feeble lower limb pulses. So shock, hypolimic shock, upper limb pulse also will be feeble, no? Yeah. Any other disease?
Sorry?
Yeah. Okay. Yes. So all this vasculitis you should bring up here. So Takayasu is among the most common causes which will cause. You must have read, no? Absent radial pulses, absent lower limb pulses, pulseless disease. This is all very typical for Takayasu. Okay, okay, go on.
Anthropometric height 137 centimeter, falls on 15th centile, weight 28 kgs, comes at the third 15th centile, weight for age 31.2 kgs, BMI 14.9.
So what is the impression from anthropometry?
Weight.
You feel is thriving well or not?
Sir?
Do you feel the
Not
child
yet.
is thriving well or not? What do you interpret? You feel the child is thriving well?
Yes, sir.
Okay, okay, go on.
Examination of abdomen, inspection, abdomen distended, umbilicus and midline inverted, all quadrants of abdomen moves equally with respiration, skin over the abdomen is normal, no dilated veins, no visible pulsation, peristalsis, visible mass, franks full, caudal edema present, hernial orifice is free, no phimosis, no discharge in the urethral orifice. Palpation, abdomen soft, no warmth, no tenderness, no palpable mass, no organomegaly. Percussion, shifting dullness present, no fluid drift, no organomegaly.
What all? What did you mean by no organomegaly? What all did you look for?
Liver span,
Okay.
spleen, kidneys.
Okay. How did you palpate the kidneys? Okay. Anything else you wanted to see if it is palpable or not? Okay. So bladder also. Okay. Okay. So you said there's so much ascites, no? With that you are very confident. There is no liver, no spleen, nothing. Okay. Go on.
Auscultation, bowel sounds present, no fluid.
Where did you look for bruit? Where did you look for bruit? Where in the abdomen? And what bruit you are interested in?
Abdominal aneurysm, aortic aneurysm.
So aortic aneurysm, where will be the bruit heard?
Umbilicus.
Okay. So are you interested in that or are you interested in something else when you look for bruit in the abdomen?
Dilation.
You are more interested in looking at renal bruit, correct? Where do you look for renal bruit?
Renal.
What causes renal bruit? Okay, so today you should go back and read it. Okay, how do you examine for renal bruit? What are the causes for renal bruit, common causes in children? Okay, you mentioned about, go back to your inspection site. The genitalia, you said there is edema, right? So somebody wants to ask, is it hydrocele or scrotal edema? How did you identify that?
Transient.
Okay, before that, before transimulation also you can tell, no, other things. What? What? Your voice is not clear. Okay.
Able to get about the swelling, sir.
Okay. With so much ascites, do you think you'll be able to do all this? You said no, there is ascites. So much ascites is already there. And was shifting dullness also present? Shifting
Yes, sir.
dullness was present, right?
Yes,
Okay. And then another colleague wants to ask, what is the common vasculitis in this age group? What vasculitis you commonly see in pediatric age group?
Microscopic polyarteritis.
Okay. So again, whenever you are asked a question, classify. It would be better if you classify and tell, right? So large vessel you tell, medium vessel you tell, then small vessel you tell. What common large vessel do you see in children?
Vaginous granulomatosis.
Is vaginal a large vessel? Is vaginal a large vessel?
No, sir.
Hmm.
Dhaka is not.
Yes. Okay. Then which medium vessel do you see in pediatrics?
Vigilance microscopic polyarteritis.
That is again small. Any other thing? That also causes hypertension. That may also cause a skin rash. That is seen in children. They may present with vague abdomen. They may present with vague abdomen pains.
HSP. Elam Charles Bucket.
HSP is again small vessel. They may present with arthralgias. They may develop peripheral neuropathy. In fact, I'm listing all the diagnostic criteria for the disease without telling the name of the disease. Okay. What is PAN? Yeah. Okay. Then what is a small vessel you commonly see? Small vessel vasculitis you commonly see. So whatever you said earlier will come in small vessel. Okay. All your granulomatous polyangiitis, all this. Okay. C ANCA, P ANCA, all this. Okay. Go on. I'll just use a chat box meanwhile if anything else is there. Go on.
A 10-year-old male child with history of facial puffiness, hematuria, oliguria, with similar episodes 5 years back, is having a renal system involvement, favoring acute glomerulonephritis, nephrotic syndrome.
Hello. What is your diagnosis?
Acute glomerulonephritis.
You still want to keep it as acute glomerulonephritis?
No, sir. Secondary glomerulonephritis.
This is secondary. How can it be secondary? Second episode. Recurrent. Okay.
Yeah.
Can't be secondary. Primary. Could be.
You don't know. You still don't know whether it is primary or secondary, right? It can still be primary.
So what are the causes of primary in this age group? What are the causes of secondary in this age group? It's a nephritic syndrome. We accept that it's a nephritic syndrome, classical nephritic syndrome. So what are the primary causes you will expect in this age group?
Glomerulonephritis primary.
Okay. That will be secondary. Okay. Okay. Yes.
Secondary cause must be IgA nephropathy.
So this say IgA is primary. What other primary cause is common in this age group? MPGN. Hello. MPGN. Hello.
Sir?
Yes, sir. You're audible, sir. Please go on.
MPGN.
Membranous
proliferative. Anything else?
RPGNs.
RPGN is not it's an it's a broad stain. Broad
Lupus.
lupus is secondary. So the primary, what are the possibilities? First one is MPGN and second is FSGS. The secondary IRGN, post-streptococcal glomerulonephritis, and IgA nephropathy, anaxagoline purpura, and lupus.
Okay.
Is lupus is common in this age group? SL is common in this age group?
No, sir.
Okay. Okay, proceed. Of
Why
this,
put nephrotic syndrome also here? Do you want to entertain nephrotic syndrome in this child?
if you want to entertain nephrotic syndrome, how will you account for hematuria? What are the causes of hematuria in a nephrotic syndrome patient?
Secondary nephrotic.
That's what are the causes of hematuria in a patient with nephrotic syndrome?
UTI, sir.
Okay,
UTI.
it's a renal vein thrombosis. Only when the patient develops renal vein thrombosis, there will be frank hematuria. So don't use the word nephrotic syndrome here. We say straight away nephrotic syndrome. Okay. Okay.
So
So
if
what
you
is
say
the,
nephrotic syndrome, then you expect all these questions. Then you are digging your
yeah,
own.
you are putting yourself in trap.
Yeah, yeah.
So define nephrotic syndrome. What is nephrotic range of proteinuria? What is nephrotic syndrome?
3 plus and 4 plus is nephrotic range of proteinuria. 1 plus 2 plus are the nephritic range of proteinuria.
Pardon? Can you repeat? I'm not able to get audible.
3 plus 4 plus proteinuria is basically nephrotic, sir. 1
Hey,
plus 2 are nephritic, sir.
Doctor, you are a pediatrician. Please mention in meter square or kg. Okay. And I'm not audible. Hello?
More than 1 gram per meter square per day. Or
1
more
gram
than
per meter square. It's okay.
Okay, it's called 1 gram per meter square per.
day.
Okay, per day is what? Is nephrotic or non-nephrotic?
Nephrotic, sir.
Okay, what else? Any other thing?
More than 40 milligram per meter square per hour.
That's good. That is the definition.
Fine. If you do a spot, because very difficult to catheterize into 24-hour sample, then what you rely mostly on spot, right? So what is a spot cutoff which differentiates proteinuria, subnephrotic proteinuria, and nephrotic range proteinuria?
Less than 0.2.
Less than 0.2.
0.22.
Okay. What would you expect in this patient? If you were to do a UPUC in this patient, what would you expect?
0.22.
Okay, you want to expect only 0.2 to 2? Okay, then why do you think he has developed so much edema? You were telling in all the pathogenesis, no? Low oncotic pressure. So how did oncotic pressure become low?
Hyperalbuminemia.
And so why did hyperalbuminemia happen?
Glomerular
Likely renal losses, right? Likely renal losses, right? Yeah. So if a child is otherwise stable, comes with minimal edema, then all this is okay. So you have to tailor your answer also based on the patient condition, right? You told me has so much edema, shifting dullness is there. In that case, just if you say I have find very little edema, then that may not be very appropriate. Understand? You always tailor your answer to the patient in question. Yeah. Okay. We'll see what. Okay. Can it be recurrent UTI?
Sir. Recurrent UTI can be good, sir.
For in this patient, do you want to entertain a differential cause for this recurrent hematuria as recurrent UTI?
No, sir. No, sir.
Why do you want to negate recurrent UTI in this patient? Sorry?
No issue with proteinuria, sir. Proteinuria will not be present in recurrent UTI, sir. No issue of a few abdominal distension.
Presence of hypertension and edema rules out.
There's so many other things also. You should keep on telling. You should be telling list of 10 things why this patient does not have UTI and why you are not entertaining that in your differential. Okay. So how do you want to evaluate them?
Complete investigation, complete hemogram, ESR, ASR.
Wait, don't read. You tell first and you tell what you are expecting. Okay, you want to do a complete hemogram. What do you expect in a complete hemogram? Okay. If the hemoglobin here was 7, what will you think? Sorry? What chronic? Voice is very blurred. Okay, go on. Then if you want to see, what do you expect in PLC? What do you expect in platelets? Where will you find thrombocytopenia? Sorry? Come on, you're answering well. Don't worry. Cheer up. Tell. Why suddenly low energy? Answer. Why do you, if you do a CBC here and you find that platelets are low, what will you think? Yeah. Okay, so AGN-like picture with thrombocytopenia, severe hypertension, you want to entertain a possibility of hemolytic uremic syndrome. Okay, fine. What else? What?
They also indicate thrombocytopenia with nephritic.
Coagulation disorders நீங்களே சொல்றீங்களே அப்புறம் எப்ப platelets வருது? You were only telling that there was history of facial rash and all you asked. Why do you ask for facial rash here? So lupus is an important cause. The child presents with glomerulonephritis has thrombocytopenia. That gives a good clue that probably you are looking at lupus. But the oddity slightly here is it's a boy. An adolescent girl comes, obviously lupus will be among your top differentials also. Okay, but that does not mean a boy will not develop lupus. Male lupus are also well known. But as you say, points for the first what will I consider, second what will I consider. So in that you will think of this thing. Any other disorders also can cause the thrombocytopenia? Okay, so go up home and read today list of causes. You should have at least 2-3 causes to tell. Okay. There's May-Hegglin anomalies and those disorders also cause thrombocytopenia. Okay, go on. Next, what would you want to do? You did a CBC. CBC is normal. Next, what will you do?
ESR.
Okay, how will ESR help you? So elevated ESR are important. So okay, ASO. How will ASO help you? You only told me already only he has had in his life at 5 years earlier. Isn't it? 5 years back only he has already had, no? So will it help now?
Yes, sir.
The KFA can still remain elevated, isn't it? Okay. What next you want to do?
Renal function test.
What do you want to see in renal function?
Urea creatinine.
Okay. What do you anticipate? Then
6 years electrolytes.
what derangement do you anticipate in this patient?
Urea creatinine.
What problem do you anticipate? What urea values and what creatinine values are expecting?
It will be elevated, sir.
Should it be elevated in all?
Okay.
Okay. How do you define RPGN? How do you define RPGN? It's like rapidly progressive, right? Okay, go on. What do you want to do next?
HGOT, SGPT, ALP, urine analysis.
Wait. Don't run. What do you
Excuse
want
me.
as you- Yes,
Excuse
sir. Yes, sir, please.
Dear presenter, when you are presenting a renal case, start with the investigation as a urine routine. Urine is a liquid gold.
Okay, sir.
Very good. Now, so many things you will start talk. இவ்வளவு இதுவரை பேசின எதுவுமே நம்ம diagnosis கொண்டு போகல இப்ப. Now the urine routine la your diagnosis will be picked up. Correct இல்லையா? So what will you expect in the urine routine in this patient? So what are the things you will look for in the urine analysis?
Urine albumin, protein.
First, how will you collect? Please listen. First, how will you collect the urine?
Early morning midstream urine sample, sir.
Like a sterile container or unsterile container?
In a sterile container after cleaning the peritoneal areas, should advise the patient to get the midstream sample of urine, sir.
Okay. And within how many hours you have to look after the sediments, look for the sediments? You can keep
Sorry,
the sample. Within how many duration you have to see with the sample? Okay. Within 1 hour we have to see the samples. Okay. What are the things you will look for?
Urine albumin, sugar deposits, and RBC cast.
So what is called as active urinary sediments?
Other learners also can participate in the discussion. Only Uma Shanti is talking.
So what is RBC cast?
Cast deposits.
So, okay. What is dysmorphic RBCs? What is acanthocytes? How much percentage it should be present to call as an AGN?
Glomerular causes may be dysmorphic RBCs. Glomerular RBCs not always not be RBCs.
Your voice is breaking.
Only the middle person's voice is clear. The other two, we are prompting, but we are unable to get it clearly. Maybe you can redirect your mic when you're talking.
Glomerular pathology, RBCs, morphologies will be altered in glomerular pathology, sir.
Why morphology is altered? Why the morphology is altered?
So what happens when they travel down from glomerulus?
Hello. It has to travel through the tubules of various osmotic pressure. So there will be a changes in the morphology due to the tonicity, change in tonicity. Okay. So what is acanthocytes? So otherwise Mickey Mouse RBCs. It should be present at least more than 5%. That is 1 in 20 cells should be acanthocytes to call it as AGN. More than 5% it should be there. Okay. Next. Urine protein. What type of urine protein analysis you will do? What type of urine protein analysis you will do?
Dipstick method.
Okay. Next. Dipstick next. Okay. That's different. So what is the fallacies in PCR? Protein creatine ratio. Spot PCR. What are the pros and cons of the spot PCR? It is drawback of relying on the protein creatinine ratio. You told us, so one of the definition is nephrotic syndrome of PCR is there. Nephrotic syndrome is PCR is there. So what is the drawback in relying the PCR? What will happen if the patient is having renal failure? It's a protein creatine ratio. The creatine will be elevated and the ratio will be altered. Okay. Next, what urine investigation will do in the urine?
24-hour urinary protein, total cholesterol, C3 levels.
Okay, you will do only C3 levels or you will do C4 along with that?
C3, C4.
So, which pathway C3 denotes and which pathway C4 denotes? Both are complements. Classical pathway is for?
C3.
C3 is an alternate pathway. C4 is classical pathway. So what are the conditions where C3 is low? What are the conditions where C4 is low? What are the conditions where both is low?
Nasally.
SLE what is low? SLE what is low?
Lupus nephritis.
Yeah. So lupus, what pathway is affected?
Classical.
Yeah. So classical pathway is affected in lupus. So what will get low?
C4.
Both, no? Yeah. C4, C3 as well as C4 will be low in lupus. Which disease only C3 will be low?
Bacterial peritonitis.
Sorry.
Very good.
Why? Your first answer is okay. Don't bring IgA nephropathy here. Okay. Generally, you expect complement levels to be normal. That's when you will suspect IgA nephropathy upfront. So C3 is an important test here to help you differentiate, right? So then you get an idea of what kind of disease is involved. Is the disease affecting the classical as well as alternate pathway, or only the alternate pathway, or the complement pathway is not the prime driver in this disease at all? Okay, so that is when you think of IgA here. Okay, C3, C4 both will be normal. Okay, so you did a urine, your basic, what do RBC cast denote? Okay, why do cast form? What forms the cast? The RBCs are getting trapped into something, no? That's why they form a cast, no? What do they get trapped into? Sorry? Okay, what is the most common protein that gets excreted in the urine? Yeah, so these RBCs get trapped with this protein also. Okay, that's why you see them as RBC casts. The presence of RBC casts is highly suggestive of what? Okay, so if you find an RBC cast, you're almost very sure that you are looking at a glomerular cause for hematuria. Okay, so like Dr. Jagan rightly pointed, before doing ESR, ASO, OT, PT and all, no, always when you're talking about a GN child, We always tell first, there's nothing like basic in this thing. Things you have to know, catch a diagnosis, right? So we would be very happy to hear what is the first thing you will want. We want you to answer is urine analysis. You tell us what all you want to look in the urine, how it will help you reach a diagnosis. Okay. Okay, what other tests you want to do? Now you did urine in this child, you get a lot of RBCs. Now you get some 3+ protein. UPUC is 2. C3 comes as 40. What will you think? Creatinine is normal. Hemogram is normal. What? Obviously, your diagnosis is already nephritis, no? You are evaluating into the etiology for nephritis now, right? We are already reasonably sure that you are dealing with nephritis. Now we want to delve into finding out what has caused nephritis in this patient. That's why we're evaluating further, right? So what would be the cause here? If C3 is low, tell 2-3 causes. C3 is normal, 2-3 causes. Again, voice is very blurred. Maybe you should turn the camera and speak to the mic.
Membranous proliferative nephritis.
Okay, so MPGN, what happens in MPGN?
C3 will be low.
Okay, so how have we renamed this disorder? MPGN with low C3. So we call them these days as? No.
Rapid progressive glomerulonephritis.
We call them as C3G, C3 glomerulopathy. Okay, all disorders with MPGN-like findings with C3 deposits, we call them C3 glomerulopathy. Okay, so that's an important cause for low C3. Okay, if the C3 comes normal, what will you think?
IgA nephropathy.
IgA nephropathy. Very good. What else? Okay, henox-online purpura. Okay, so can HSP recur? You did you ask for history? Did you ask for history of lower limb predominant rash in the past also? You said there's no history of lower limb rashes now. Did you ask for history of rash in the past?
No, sir. No history, sir.
That 5 years of age when he had a hematuria, that time did he have that?
No history of rash, the lower limb rash in past history.
There is no history of lower limb rash. So can henox-online rash recur?
No. Yes, sir.
Yeah, so recurrence is common. In henox-online, on seeing the child only, how do you know who all will develop nephritis? So what are the risk factors in henox-online for a patient to develop nephritis? Okay, maybe slightly difficult for your level. What findings do you find in henox-online nephritis? What happens? What happens in the kidney because of henox-online?
Immune complex deposition.
Okay. Okay, so what is a new name for henox-online now? How do you call it? We no longer call it HSP. We call it what?
IgA vasculitis.
Yeah, very good. So normal C3, two easy things you can say is IgA vasculitis, IgA nephropathy. Okay, IgA vasculitis is your henox-online, and then IgA nephropathy. So easy to remember for you. Okay. Okay. What else will you do?
USG abdomen, renal biopsy.
Wait, don't jump. What findings you want to see in an ultrasound?
Morphology of kidney.
What do you expect? What exchanges do you expect by now? What changes in morphology radiologically you see? Do you expect the kidney to be shrunken? If you say the kidneys are small in size, what will you think? Sorry? So the kidneys are small in size, what will you think?
Renal failure, sir, that is perfusion. Any thrombosis, chronic kidney.
So that means the hematuria that happened at 5 years has led to a significant sequelae. Okay. So that's why then probably you're looking at a CGM here, maybe. So because of that, now the kidneys have started to go down in size. Okay. How do you know this kidney size is normal or not for a child? How do you know that? Okay, so remember, charts are available for this also. So one thing you should remember in pediatrics is for everything you have a normal value. From heart rate to respiratory rate to blood pressure to everything has a normal value. Even all your changes in ECG, QR complex has a normal value for HP, QT, interval, everything has normal values for various age groups. So it's up to us to go back and read, find out and read. Okay, so ultrasound also has kidney sizes which are given. You can make even Z score. Apps are also there which will help you give Z scores. Then you will know whether kidney size is small or not. What else do you see? You will look for increased cortical. If the cortical echogenicity is increased, what does it suggest?
Chronic medical renal disease.
Okay. If you find acoustic shadow in ultrasound, what will you think?
Mass, abdominal, renal.
Child also has colicky pain.
Cystic disease of kidneys.
So you'll think of stones.
Renal.
Yeah, so kidney stones are typically ones which leave an acoustic shadow. You find the stone, and then below the stone you find like a comet-like thing. Okay, so that is very clear that probably you're looking at a stone there. Okay, what are the other causes for increased echogenicity in the kidneys? Okay, if I find medullary nephrocalcinosis, what will I think in a child with glomerular recurrent hematuria?
Hypercalciuria.
Yeah, so hypercalciuria can lead to medullary nephrocalcinosis. How would you define hypercalciuria? Yeah, correct. So anything more than 4 mg, okay, then that is called hypercalciuria. In a 24-hour urine. If you are unable to collect a 24-hour urine, then you'll do a spot. What are the cutoffs in spot?
More than 0.2.
More than 0.2 in. So this again is age dependent. Okay. So based on age, it is different. So less than 1 year, 1 to 2 years, 3 to 5 years, more than 5 years. Okay. So more than 5 years, anything more than 0.2 is generally considered abnormal. Okay, now you have done all this, you didn't find anything. Everything is okay. What will you do next?
Biopsy.
Before
Excuse
biopsy.
me.
Yes, please tell me. Yeah.
Your case is as a classical presentation of hematuria, pedal edema, hypertension. Am I correct? Hematuria, pedal edema, hypertension. What about the C3 values in your patient? Low. So it's a classical AGN. So if it is your first possible diagnosis is PAGN, that is post-streptococcal, what we call as IRGN. So of the 4 parameters you mentioned, that is hematuria, hypertension, edema, if possible renal failure. What is the order of recovery? Before going to the biopsy, you should know this. In which order it will recover? Which will the first? Pardon?
Edema and hypertension first resolves in 7 to 10 days.
Okay.
Followed by hematuria, then proteinuria.
Okay, proteinuria, then hematuria. Hematuria, how much it will take to recover?
2 weeks for proteinuria, 2 to 6 weeks for proteinuria.
For hematuria? It's a 4 to 8 weeks. 4 to 8 weeks. Microscopic hematuria will be there. Okay. Then C3, when you return back to normal level? Hello? C3. That in other words, if the C3 is persistent for beyond how much period, you will go for biopsy.
More than 1 month.
No. It's 3 months. Okay. Now go for the indications of biopsy. What are the indications of biopsy in the acute glomerulonephritis?
Persistent hematuria for more than for 6 weeks, sir. Frank gross hematuria for more than 6 weeks.
Okay, next. Not a clear indication. Next is
Start with important indications, no, where there's no controversy.
Sir,
rapidly progressive renal failure, persistent renal failure for more than 4 weeks. First is rapidly progressive renal failure. You have to go for biopsy because we have to start with immunosuppressant. So that is the first. Next is the persistent renal failure for more than 2 to 3 weeks. And third thing is low
mixed
complement. Solunga.
Mixed nephritic and nephrotic.
So that,
Sir.
Very good. And with systemic symptoms, very good. Regarding C3 level, when we'll go for biopsy?
there are two indications with respect to C3 only.
Hello,
Sir,
voice is breaking. Hello.
Low C3 level for more than 1 week, sir.
No, more than 3 months. Isolated C3 for more than 3 months. You have to go for biopsy.
systemic hypertension for more than 1 month.
So if the C3 is normal at onset, will you biopsy?
Normal C3 level in active disease indication for renal biopsy.
So that's also an indication for biopsy. Okay. So
Why
this kind of
why in
why-
IgA nephropathy the C3 is normal? It's also a glomerulonephritis. Why in IgA nephropathy C3 is normal, but in other glomerulonephritis like SLE, IRGN, it's low. Whether the complement is activated in IgA nephropathy or not. Whether the pathogenesis of IgA nephropathy involves complement pathway or not. It involves complement pathway, but there will be no lysis. Yeah, there will be no membrane attack complex formation. The effect will be sublytic. So we can't expect a low C3 in patient with IgA nephropathy. So a nephritic syndrome with a normal C3 mostly goes with IgA nephropathy. Okay. So two indications for C3 with biopsy. One is normal C3 with AGN or persistent low C3 of more than 12 weeks. Okay. Are you able to follow?
Yes, sir.
Continue. Next. What will you expect in biopsy? Have you seen any biopsy? Loud, please.
Mesangial proliferation.
Mesangial proliferation. In post-streptococcal, what you will see? In the light microscope, what will we see? Will you see in
complex deposition, sir.
light microscope? Endocapillary hypercellularity, diffuse proliferative endocapillary hypercellularity will be there. That is the reason for oliguria and edema. Okay, and even hypertension. IF, human fluorescence. Very good. Proceed. How will you manage? If it is going to be post-streptococcal glomerulonephritis, how will you manage? If it is going to be IgA nephropathy, how will you manage?
Salt restriction diet, fluid restriction diet.
Okay, you will restrict fluid, you will restrict salt. What else? So there is hypertension, no? You saw BP is 161. What will you do for that? What is your what is your
Calcium
what is your hypertensive of choice in a child with AGM?
channel blockers, ACE inhibitors.
So if it is PIGN, is calcium channel blockers the hypertensive of choice?
Diuretics.
Yeah, so diuretics are also good antihypertensive. Diuretics are the antihypertensive agent also. So how much will you give? What will you give?
Sir?
How much diuretics will you give? What will you give? Okay, so you want to give 4 mg per kg per day of furosemide in 2 divided doses. Okay, what else will you do? Now BP does not fall. You have given a dose of furosemide, BP does not fall. Then you will probably add calcium channel blockers. Will you consider AC inhibitors in AGN? Those are the only group of drugs you should never commit.
No,
Should never tell. Why you should not give AC inhibitors in AK, any AK for that matter?
because hyperkalemia.
So that is so counterproductive. If you give AC inhibitors, you may lose the patient. Patient may develop hyperkalemia and die in front of you. So remember, never give AC inhibitors to any patient who is in AKI. It may not be a RPG and it may be any cause of AKI. Okay. So first you will start off with diuretics, then you will add this thing. You will add salt, make salt restricted diet. Okay. What else will you do? Do you want to give an immunosuppression therapy for a PIGN? Creatinine is normal. Other things, would you want to give? So you generally do not give, and you just monitor the patient, monitor his hypertension, look at his other parameters, and see how he improves. Correct? Okay. Now, if you find, if you get IgA nephropathy, what do you want to do?
AC inhibitors can be tried to reduce glomerular hyperfiltration.
No, but not at the acute stage. No, not at the acute stage. No, child has just now come with RPGN like picture, creatinine if it is deranged. Then this time I would not give ACE inhibitors upfront. Correct. So you will give other things, and what else? So you will basically at your level you just tell I would start immunosuppression for these patients. Okay, what immunosuppression, how much, when, what may not be required for you. If you have features of lupus, what will you do on the biopsy?
Viral loop lesions.
Okay, so you'll get viral loop lesions, and you are aware of any staging system?
Stage 4 stages.
6 stages.
So there are 6 stages. Okay. You don't need to know the stages and all. You just know that there are 6 stages, and based on what you get on biopsy, you tailor your immunosuppressive medications accordingly. Is that okay? Okay. Any other drugs you want to add in lupus? You'll give immunosuppressive agents. Anything else you want to add? Another important drug which has high toxicity. Specifically, you give it in lupus patients. And then you ask patient to look at eye checkup also after 5 years. In lupus, apart from immunosuppressive medications, what else do you give? Okay, so we add hydroxychloroquine also, no? HCQ. Correct? So HCQ is also an important part of therapy. Apart from that, bone health also has to be taken care of, and you ensure that patients apply sunscreen regularly. Okay? Because it is the photosensitivity. Lupus has exquisite photosensitivity. Sun exposure may trigger a cascade and may lead to renal flares. Okay? So regular use of this thing is also advised. Okay. Now, if you get a MPGN like picture on biopsy, what will you do? I'm just trying to give different possible answers for your particular patient in question so that you know how do you treat them. Correct? That's what I'm trying to say. So if you have got an PIGN, now you know what to do. If you've got lupus, now you know what to do. If you've got MPGN, what will you do?
Plasmapheresis.
Okay. Why do you want to do plasmapheresis?
Remove immune complexes.
Okay, but we generally don't do plasmapheresis upfront. Okay, in that case, then lupus is also totally an immune complex disease only. So there are very few indications where you do plasmapheresis. Maybe at your stage again, it's not required that you know all this, but you should again be able to tell us that you will start immunosuppression upfront. Okay, if you get C3 glomerular nephropathy, C3 glomerulonephritis, then you should be able to tell us that you will start them on immunosuppressive medications. Okay, and then good blood pressure control and all other supportive care to be given. Fine. Okay, what are the indications for dialysis in this child? When will you consider doing dialysis in this child?
With elevated urea creatinine.
So, okay, so urea is 90, creatinine is 1.4. It's elevated urea creatinine. Do you want to dialyze? So it is not just elevated urea creatinine, isn't it? So don't tell elevated urea creatinine is an indication to dialyze. So how much elevation is significant?
More than 3-fold.
There is no such definition for an urea and creatinine for dialysis. It's a symptom and it's a life-threatening conditions. Okay. Here the number doesn't matter. Even GFR doesn't matter. What you need is the presence of pulmonary edema, presence of hyperkalemia, presence of refractory acidosis. Presence of
Let them give the answers. I was hoping they'll tell all this. Tell. So you should tell us that there is no numbers which decide, but if the patient has symptoms, you would definitely go ahead and do dialysis. So just don't say elevated urea creatinine. Okay. So that is one. What else? The service help you with. That is what we discussed all this. No? That is what is uremic symptoms. Okay. Then what? Potassium is 6. What will you do?
Anuria, sir.
Okay. Anuria persisting. Okay. Plus minus. Then? Hyperkalemia is an indication. So you get potassium of 6, you will initiate dialysis? Generally, what we say is refractory, right? But in this setting, this potassium of 6, I would generally think ahead and go ahead. While do medical management, prepare the patient and think about going ahead with dialysis. What are the other indications? Child is having severe tachypnea now. What will you think? Anuric, severe tachypnea. Yeah, so pulmonary edema. Pulmonary edema is an important indication in this child to go ahead and do dialysis. Okay. What else? So refractory acidosis, refractory hyperkalemia, uremia complications, anuria persisting for a long time, pulmonary edema. These are all indications to dialyze. Okay, clear? Now, what dialysis you want to do? You want to decide on which mode of dialysis you want to do?
Peritoneal dialysis.
Why PD? How do you decide? Do you want to do PD? You want to do HD? How do you decide? Okay, a lot of it depends on what is your expertise, what is available with you. Any modality, when done properly, is good. Okay. Okay. What important counseling and advice you'll tell to the parents for this child while you initiate therapy? You have to counsel the parents also, right? Simultaneously. What all important things you'll tell to parents? Sorry?
Nutrition.
What will you say in nutrition?
Yes.
What nutrition advice you'll tell?
Salt
Nutrition is the one thing which mother will be extremely concerned and keep on asking you, no? They'll ask you, no? So what will you tell?
Protein.
Protein?
Low protein restrictions.
Why you want to restrict protein? Already catabolism is happening. You restrict further, you will worsen it further, no? So generally, there is nothing like protein restriction in pediatrics. Okay, there are very few conditions. So generally, don't tell protein restriction. Okay, you allow normal protein, normal calorie. In fact, you have to give more than what is routinely recommended because your basal metabolic rate is increased. So what we generally say is give about 130% of your routine calories. Okay, how much ever calorie child is usually expected to take, you give 130% of that. Okay, to compensate for the increased metabolic needs in this patient. Okay, otherwise catabolism will happen, more protein breakdown will happen. That will add more to the injury, no? And then protein restriction is not required. Okay, all that is required is salt restriction. The child is anuric, child is edematous, then fluid restriction. Okay, what all food you can give, what all food you should avoid. Sorry?
Items.
Yeah. So what that?
Pickled salt.
The mother is asking, can I give chicken? Can you give chicken?
Yes, sir. Yes.
Okay. Fine. How will you follow up this patient now? Sorry?
Regular BP monitoring of this patient, urine album and urine analysis.
Yeah. So all the indications for biopsy you said, no? If that indications for biopsy don't satisfy currently, you should look for all of those in follow-up. If the nephrotic range proteinuria persists beyond 2 weeks, if your gross hematuria persists beyond 1 to 2 weeks, okay. If your microscopic hematuria may take longer, sometimes it even is there up to 6 months also. Okay, if those things persist, the hypertension is persisting beyond 4 weeks. So these are all again indications. If you're not already biopsied, in follow-up, you should remember that you should look for all these things, and then you should consider biopsy in such children. Okay, important to monitor hypertension in follow-up, and remember 1 episode of AKI itself increases the risk of developing CKD to a great extent. So all these patients need to be regularly monitored. Okay, look for creatinine and follow-up. Look if the urinary parameters are normalized. Okay. Okay. Is there any role for genetic evaluation in this child? Do you want to do genetic testing in this child? Will it help?
No.
Why?
No.
Why will it not help? These days, no, genetics have taken over. A lot of pediatric renal disorders can be diagnosed by just genetics. So you didn't tell us, are you going to do eye evaluation in this child?
Yes, sir.
What will you look for?
Cataract.
Cataract.
Shape of the
glaucoma. Why glaucoma? Why cataract?
cataract.
You have not even started steroids, no? Follow-up, you mean? Okay, what else? Yeah, so what are the features of Alport in the eye?
Lenticonus, cataract, macular dystrophy.
Macular flex. Okay, so you'll have to look for all these things in eyes. Okay, what is the? You should also do. Will you do hearing? Yeah, so you'll do a hearing assessment in this. Okay, and another important thing, you will also ask for mother's. You can request the mother to undergo a urine routine. Okay, to see if mother has hematuria. Yeah, mother has hematuria. Okay, so that is a very strong clue even before you go ahead and do a biopsy. No, so many simple bedside tests will help you clinch a diagnosis. You just ask mother and ask her to do urine routine. If you find RBCs in mother's urine, then what are you thinking? So you're again thinking of Alport. Okay, so probably the call X-linked Alport. Mother is also having, child is also having, and this is recurrent also in this child. Understood? Okay, so in this setting, genetics also has a role. Okay, because Alport is a single gene disorder, X-linked Alport has only one gene, call4A5, and autosomal recessive and dominant have two genes, call4A3, call4A4. So these days you can even do a genetic testing and specifically look for all these things. Okay, there are only few diseases. Like for lupus, doing genetics is not going to help. For IgA nephropathy, doing genetics is not going to help. But a boy with recurrent hematuria, where you are suspecting Alport, then yes, genetics definitely will help you clinch a diagnosis. Okay. Is there any specific finding in biopsy finding specific for Alport?
Sorry for interruption. Can you finish it within 5 minutes, sir?
Yes, sir. We are almost done.
Yeah.
We have almost covered.
Almost 10 o'clock, sir. Yeah.
Yeah, we have almost covered. Yeah. So yeah, so basket weave appearance is very typical of Alport. So you get that on electron microscopy. We don't routinely do it, no? We might miss it. And remember, it is also age dependent. A child presenting at 2-3 years may not really have this basket weaving, but as the child ages up and becomes an adolescent, you might pick up. Okay. So in such patients, many times what we do, the algorithm is slightly changed. If there's a strong suspicion of Alport, then instead of even doing a biopsy, you might directly go ahead and do a genetic testing and try and see if their call4A5 is affected. Okay. That is just to add. Even if you don't tell genetics, that's okay. But just that you know it. Okay. Okay. Any doubts?
Sir, I have a sir. 1 minute, sir. I have a doubt, sir. This patient we have treated in Sivagangai, sir. But
Yes,
nephrotic picture is how common in which type of nephritic, sir? This child had some scrotal edema, moderate ascites, and somewhat high spot PCR and hypoalbuminemia also patient. Sir.
Yes, ma'am. So about 30 to 40% of these patients, we generally have nephrotic range proteinuria to begin with, but they generally resolve very quickly. So if it persists beyond 2 weeks, then we would generally think about biopsying such patients also. Many, because we are sitting in a tertiary referral center, we very commonly get this nephrotic range proteinuria, but we don't upfront biopsy them. If the other findings are not there, we will wait for about 1 to 2 weeks and see, follow up the patient. If the nephrotic range proteinuria resolves, then we don't do anything. But if it persists, then we'll definitely do a biopsy.
Okay, sir. Thank you.
Yes, ma'am.
Thank you, sir. And because of IAPTNSC, really thankful to Sivagangai Medical College team. They presented very nicely. Now I request our judges to comment, please. Dr. Ramesh, sir, please.
Another day of interesting case discussion. Well presented case, well worked out case. The moderators started with the basics and went on into in-depth discussion covering all aspects. The students also did well, though they were able to answer most of the questions. I felt they were little appeared less confident. In a PG examination, you have to appear confident even if you are not. And you should know that it's all postgraduates. You are given a fresh case that you have not seen. Even if you have seen that case earlier, you have to pretend as if you have not seen that case and ask questions. So in this case, it looked as though you know the diagnosis and presented a case related to that. You have to ask, like your chairman and Dr. Guna said, you should ask first, find out questions to find out which system is involved. Then after boiling down to a particular system, ask questions related to the various diseases in that particular system. And then slowly proceed to the ask questions to rule out some of the diagnosis or to confirm your diagnosis and give a long list of diagnoses. The more number of diagnoses you give, the more knowledgeable you are. That's what the examiners will feel. And in this particular case, if it is a multi-system disease, you have to cover a large ambit of differential diagnosis like SLE, HSP, polyarthritis, nodosa, acute tubular, even Wilms tumor. Even if there is one point to think about the diagnosis, you just mention only to rule out that particular diagnosis. Otherwise, the discussion went on well. I should appreciate the moderators also and the presenters also. Thank you.
Thank you, sir. Dr. Rama Chandramohan, madam.
First of all, I want to thank the moderators, Dr. Sudarshan and Dr. Jagan. I made it a very, very interesting session. We learned a lot of things, much beyond what we normally discuss in AGN. I think that's why the PGs were, looking little bit, they were intimidated by some of the questions I felt, but you did a good job, girls. You were, except that in some places we couldn't hear you very well. Otherwise, you did, I mean, whatever was needed for the exam point of view, I think you answered. And over and above that, there were a lot of interesting questions. And I hope somebody, I mean, I'm sure it is recorded and it will benefit everybody, because I like the type of discussion. It went off very well. Thank you.
Thank you, madam. And behalf of IAP-TNSE, really thankful to Dr. Guna, madam, and she's a professor and HOD. And I thank Dr. Sudarshan, Dr. Jagan, who has moderated very well. I thank all postgraduates extremely, they've done very well. And once again, I thank each and every one of you. Madam Guna, madam, you want to tell anything? Yeah.
Yes, sir. It is first of all, I want to really thank my postgraduates, because all these joined just 4 months, 5 months back. For that, for the time duration, it is I couldn't expect much more than that. It's really good work from my PGs, and I have to thank
First year,
the
they
whole.
did a good job.
Yes, sir. And I have to thank the IAP-TNSE, and I have to thank you, sir, and the judges, moderators. Really, as madam said, the questions and the approach, it's very giving much more information to us also, sir. Thank you so much for this opportunity and the program. Thank you, sir. Thank you.
Thank you, madam. Thank you very much, madam. Thank you.
Thank you, sir.
Thank you. Good night.
Good night.
I would like to thank our chief chairperson, Dr. Guna ma'am, our HOD ma'am. I would like to thank the moderators, Dr. Sudarshan sir and Dr. Jagan sir, for teaching us more valuable points in acute nephritis, acute glomerular nephritis and nephrotic syndrome in renal involvement. I would like to thank all the faculties nowadays. Thank you, ma'am.
Thank you.